Welcome to another surgical ICU discussion. We'll discuss infection control in the ICU patients. Since we are discussing about infection control, we first of all need to know what we are controlling. We are controlling the organisms which come either from the patient themselves or from the hands of the ICU personnel. The most commonest gram-positive organisms isolated from the ICU personnel are Staph aureus and Staph epidermidis. The gram-negative happen to be Serratia, Pseudomonas, Enterococci, Acinetobacter and Klebsiella. The most commonest fungus is Candida. When you see these species, you actually think to yourselves that most of the organisms cultured either in your urinary catheter or the venous catheter, arterial line, and even your tracheal aspirate happens to be these organisms. And sepsis caused by them can be quite serious, and at the same time it costs a lot of money for the antibiotics. Not to forget that your patient is put at a very high risk. Therefore, controlling these infections is very important. Many ICUs have a policy that the personnel should use an antiseptic on entry and exit of the ICU at the same time before contact with the patient. Different agents that are used are either alcohol, it's known to cause skin dryness, it's having a broad spectrum, and it's rapidly effective against 99.9% organisms. Iodophores, on the other hand, have a very broad spectrum. They have a slow onset of activity and they can actually irritate the skin. Another thing about iodophores is that you should allow them a contact time for at least 3 to 5 minutes. There is no fun of painting an area with betadine and wiping it off the next second with alcohol or saline. It doesn't make any sense. Chlorhexidine has a narrow spectrum of action, but it has a good residual activity going on for almost about 3 to 4 hours. So that's the plus point of chlorhexidine. But remember that none of these antiseptics are sporicidal to Clostridium or Bacillus. Therefore, always wear gloves when you expect to be in contact with these kind of organisms. Hand washing is an ideal thing to be done on many occasions before and after encountering the patient. Most of the time it is met with poor compliance because the recommendations are neither practical, achievable, or affordable. Many times it happens in your ICU that you walk there and you find there is no chlorhexidine or there is a lack of tissue paper. Sometimes it so happens that the sinks are either blocked or they don't have any water. A hand wash prior to and immediately after the use of sterile gloves is essential because in case the glove tears during a procedure, there are lesser amount of organisms or potentially dangerous organisms to be in contact with the patient tissues. And at the same time, even though one has washed up and worn a glove, the buildup of moisture in the gloved hand itself can cause bacteria to build up. Most of the unsterile gloves are made of latex, and repeated exposure promotes hypersensitivity. Latex allergy is about 1% in the general population, but almost about 10 to 20% in hospital workers. Therefore, use vinyl gloves in the likely event that you are allergic to latex. Many procedures in the ICU, such as suctioning, taking off a dressing, or let's imagine removing a chest tube or a drain, can actually cause aerosolization of particles and infectious materials. A mask can protect us from airborne infectious particles, whereas a respirator can protect from inhaling dangerous substances, including infectious particles. The infectious particles are divided as per their sizes. One which is less or equal to 5 microns can travel long distances. And patients harboring these kind of organisms should ideally be isolated in a negative pressure room. Why the negative pressure? So that when you open the door, all the air gets driven towards the patient as opposed to away from the patient. It's also necessary to wear an N95 mask while handling these patients. An N95 mask is a mask which can prevent non-oil based or aqueous particles to be filtered up to 95%. Organisms more than 5 microns can travel up to 3 feet, and therefore masks are enough to protect oneself. A hollow needle usually has about 1 microliter of blood, and this 1 microliter of blood can have up to 5 HIV organisms or up to 1 million HBV particles, which tells you that HBV is more infectious than HIV. In the likely event that the skin or mucous membrane is broken and few HIV particles fall on the unintact mucosa or skin, there is a 0.09 rate of seroconversion, which is hardly anything. Whereas, if there is a single prick, it carries a risk of 0.3% rate of seroconversion, which is a very high percentage compared to that when the organism falls on unintact skin or mucous membrane. The post-exposure prophylaxis for a victim who has got injured with a needle stick for HIV exposure is zidovudine 200 mg TID along with lamivudine 150 mg once a day for a month. If supposing the source of HIV is symptomatic, then one needs to add more drugs. And the unfortunate victim should be tested 6 weeks, 3 months and 6 months after the exposure, because the antibody response takes around 4 to 6 weeks in the victim. It is best to get vaccinated against hepatitis B because, as you have just seen, 1 microliter of blood can carry many infectious particles. And if unvaccinated, the risk of seroconversion is 60% and the risk of clinical hepatitis is 30% after a needle prick with HBV. The schedule for vaccination is the first dose on the 0 month, second dose on the first month, and the third dose on the 6th month. In the likely event of a person being unvaccinated, the post-exposure prophylaxis is 0.06 ml of kg per kg of the HBV immunoglobulin, and to start the vaccination at 0.16. Following the needle prick of a patient who is having HCV, the risk of HCV infection is 1.8%. The gastrointestinal tract is open, like a donut. The mucosa is about 1 millimeter thick. The population of the Earth in 2005 was 6.5 billion, whereas 1 gram of stool has 10 to 100 billion microbes. So one can understand that the population of 1 gram of stool is more than the population of people on the Earth. Now, if you see the range of the colony forming units per ml of secretion, the oral cavity is 10 to the power of 5 to 6. The stomach is a little lesser because of the acid. And as one goes to the bowel and the rectum, the concentration increases. The different mechanisms to prevent infection of the GI tract are the gastric acid, the intact mucosa, and the reticular endothelial system. But in the likely event of there being a microbial overgrowth, loss of a mucosal barrier, which can occur when there is reduced or impaired blood flow, there is a defective clearance of these organisms by the lymphatics. Thus the bacteria move from the mucosa to the submucosa, and they also go outside to the serosa, and this is what causes bacterial translocation. Once the bacteria are in the lymphatics, all hell breaks loose. For ideal circumstances, the mucosal lining of the GIT is replaced every 2 to 3 days. But when there is an impaired blood flow, mucosa doesn't get replaced, the epithelium gets denuded, and the gastric acid damages the denuded portion of the stomach. Thus, there is infection and translocation. Therefore, stress ulceration occurs not due to acidity, but due to decreased blood flow. When there is a reduced gastric acidity, again which occurs because of reduced gastric blood flow, there is an increase in GIT infections. When the patient is intubated or even otherwise, there is some degree of aspiration, and pneumonia can occur from this aspiration. There could also be septicemia due to the bacterial translocation by the mechanisms explained earlier. The stress-related mucosal injury erodes into the mucosa, bores into the submucosa. Thus now there is infection and translocation. Usually 75 to 100% of your patients get erosions within 24 hours of an ICU admission. And without prophylaxis, 25% of these patients can actually develop bleeding, and 1 to 5% of patients could have significant bleeding. The high-risk conditions for the bleeding are patient on mechanical ventilation for more than 48 hours, a coagulopathy with reduced platelets, increasing INR, a PTT going twice above the normal, hypotension, sepsis, multisystem trauma, head injury, burns, and renal or hepatic failure. In your trauma patients, all these mechanisms are very common because of the mechanisms of injury plus the failure that occurs as a case of polytrauma. Thus, what are the preventive measures that we have to see that a patient doesn't get a stress ulceration? First of all, we can preserve the gastric blood flow. This is something which is not entirely in our control, because how can you dictate what happens and which blood goes where? But here it's necessary to see that the patient doesn't get hypotensive. Second of all, start the enteric nutrition as soon as possible, because it can reduce the incidence of GI bleeding. Cytoprotective agents such as sucralfate can be used, but the bleeding incidence is more, but the pneumonia is lesser. Whereas when H2 blockers are used, there is a lower bleeding incidence and more of pneumonia. This tends to show you that H2 blockers have a better control on the acid. Therefore, having a lower bleeding incidence and more pneumonia because the acid is not able to act against the organisms. PPIs are very commonly used, like omeprazole or esomeprazole in the ICU patients. We have observed that maintaining the gastric blood flow or cytoprotective agents can actually help against stress ulceration, because the fear is that once there is a stress ulceration, there is a bacterial translocation. Another method to prevent the bacteria from being there is a decontamination method. As we had seen earlier, 1 microliter of saliva has 10 to the power of 6 microbes, usually which are lactobacilli and alpha hemolytic streptococcus. These are commensals. But Pseudomonas, which is a gram-negative organism, can easily colonize the oral cavity when the patient has been intubated, or in cases of polytrauma, maxillofacial injuries, head injuries, etc. A method of oral decontamination is taking a 2% paste of colistin, gentamicin and vancomycin and applying it on the buccal mucosa every 6 hours till the patient is extubated, with the hope that there is less amount of microbe in the saliva, less chances of aspiration, less chances of pneumonia. Whereas a digestive decontamination can be done to reduce the incidence of pneumonia, UTI, and vascular catheter related sepsis. Remember that this reduces infection rates and not mortality. Here a paste of 2% polymyxin, tobramycin and amphotericin is applied every 6 hours in the oral cavity, whereas for the GIT, a solution of colistin, tobramycin and amphotericin is instilled every 6 hours. systemically, cefuroxime is given for the first 4 days. There has been a lot of debate about these protocols of decontamination because they don't reduce the mortality, they only reduce the infection rates, and they also reduce the length of ICU stay. The risk and benefit of both have been debated for quite a while, but even though this protocol is worth mentioning. Thanks for watching. Like, comment, subscribe, or email me.